Derek. I hope everybody had a pleasant December into January transition. I think the last time we were all together, Elizabeth yelled at me and triggered some flashbacks of my mother. So I had to go into hiding. But I'm Derek. I'm a counselor. I work at Mount Pushkar Health Right. I'm also an educator, an adjunct professor at WVU and a master of the dark arts. And this is a throwback to when I won a giant stuffed llama at an elimination dinner. There were many grandmothers who were upset with me that I won it and they did not. One of them tried to do a drive-by as I was leaving, but I fought them off. So it's now my llama, and that's my pineapple floral shirt. And we can progress to the next slides. We're going to talk about communicating relapse, because sometimes there's a lot of confusion about what that means, how to go about it, how do we talk to our clients about it, how do we get them to talk to us about it. So kind of going into the interpersonal communication side of it. Next slide. There we go. So I think we all know by this point, addiction is a chronic and relapsing condition, and that most people within the first year are going to relapse. Not to say that all of them are, but a lot will, and that's fine. Relapse is kind of looked at in many different ways. There's a relapse versus return to addiction or active addiction. And then if you get into more of the nitty-gritties, and a lot of different peer-based communities will tell you that there's a difference between a lapse and a relapse. And this is why the recovery model is often judged for being very vague. So it kind of is. But being able to kind of judge what's going on with somebody, but there's also, we have to look into if they've used again and they come back in, have they entered into recovery? But then that also is very vague. So we want to try and process what's going on with them, where are they at in their process of recovery or entering recovery, and how can we facilitate them getting back into that? So that's kind of what we're going to go into today. So recovery is a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. I'm pretty sure over the past year, we've heard this at least 5 different times in all of these didactics, but this is the SAMHSA definition of recovery. But they've also broken it down into 4 different dominions: health, home, purpose, and community. For health, learning to overcome, manage, and more successfully live with symptoms and making healthy choices that support one's physical and emotional well-being. For home, having a stable and safe place to live. Purpose, meaningful daily activities such as a job, school, volunteer work, or creative endeavors. Increased ability to lead a self-directed life, and meaningful engagement in society. Now, this is where it can get a little bit weird in interpretation, depending on who you're talking to, of what engagement in society means. But for community, relationships, and social networks that provide support, friendship, love, and hope. We always want to help them build all of these areas of their recovery or just their life in general, especially community. So, 10 common dangers for recovery. Not to say that you're only limited to these 10 or that any of these 10 have to be experienced by any of your clients, but the most common: being around familiar drugs, drug users, or drug-related settings, experiencing negative feelings or celebrating positive ones, experiencing boredom, which is often the most difficult to try and work with, getting high on any mood-altering substance or behavior, experiencing physical pain, focusing on getting high, sudden excess of money, taking a prescription medication that causes a high, or believing that occasional drug use without a problem is possible. You might often hear these things referred to as triggers, and sometimes you'll want to talk about triggers. And maybe in most cases, this will be something that comes up as you're talking to clients of what led to a relapse. They might say something around these lines, or they might say that dreaded line that I hate, and I always try to tell my clients to give me more details: people, places, things. A lot of the little 12 tradition sayings tend to become a empty platitude, and I like to try and dig into what's actually being communicated to us. But that's me. I'm kind of a stickler and mean, so we'll get into more of what that means. These are the common dangers or triggers for recovery. So here's your 3 causes: losing touch with the pain of addiction, cross addiction, and overconfidence. When you have any number of triggers, and then you're in a mindset of one of these 3 causes, this is what places somebody at high risk for relapse. So say they're around people they used to use with, or in places that they used to buy from, and they kind of lose touch with the pain of addiction, or as some might know it more familiar, glorifying substance use. Kind of having that, oh, well, I remember it used to help with pain or anxiety, whatever it might relieve for them. And then they're in those triggering settings. That's what kind of pushes them closer towards activating an actual relapse. But probably the one that gets talked about the most is overconfidence. Oftentimes you'll hear them say, the moment you think you got this is precisely when you do not got it, because then you're getting a little bit too complacent and you start to lax on different things. So what can we do? We can facilitate non-judgmental discussion, identify relapse triggers that lead up to it, the relapse before the relapse, meaning all the different steps that kind of built there, and reassess what their motivation for recovery is. We can use the, old reliable tools like the stage of change model or motivational interviewing. Those seem to be quite effective. We can assess relapse of basic needs. If there's something going on within their life or with them personally, if they're not eating right, if they're not sleeping well, if they're overworked, if they've not taken their medication consistently, or if they need to come in and talk about more things interpersonally. All of these things can affect that mindset that might push them over the edge if they are around a lot of different things that are triggering them. So what a lot of the peer-based recovery groups will kind of go over with newcomers is the HALT acronym, HALT, where they'll talk about, are you hungry, angry, lonely, or tired? And all of those things, if you're feeling hungry, angry, or isolating yourself, that can put you at a higher risk if something else comes into play. And I always like to, if we're going to talk about the relapse as a teacher, not a failure, I always say it's not a failure, it's a fumble, or I might use a different word that starts with an F. But if you look at it like you failed, I messed up, I relapsed, I'm a failure, then that's going to lead to the feelings of feeling like a failure, feeling shame, guilt, and then that is going to lead into potentially continuing to use or other behaviors that might be destructive. So if you look at it like a fumble, hey, yes, I messed up, but I can still pick the ball up, or somebody can help me and we can keep going. So it all depends on what is going on in their mind as a result of the relapse. So enabling forces, we can kind of dig into what us as providers can do. Are we kind of looking into things that we might be helping them overcome, things that we might be covering up for them? What consequences are we removing? And different ways that we might be able to mitigate that, but not get into, punishment or being too mean. So next slide. Thoughts, cravings, and urges. This is one that I try to do a lot of education on because there are different things here. And often when you start to talk to clients, did you have any cravings or urges, or did you have thoughts of using? They might not know what you're referring to, or maybe you don't know what their understanding of these different things are. Most clients know that a thought of using is just that, just thinking about using, thinking about the preparation work, getting things ready, getting supplies ready. Who would they contact if they wanted to? just those little things that kind of pop into your mind. But cravings are when you have that particular itch for something. And that could be that positive outcome expectation. If we're talking about the glorification of substance use, positive outcome expectations is I'm having a bad day, I'm really stressed, or I've been working a lot of hours, I'm exhausted, I can't keep going anymore. But I remember when I did meth, it kept me up for a while and I was able to focus and get things done. That's a positive outcome expectation. Whereas they could divert away from that and try a different coping skill or a different method. But when they start to get that one thing that they want and might have some kind of positive outcome in their mind, that's a craving. An urge is when that moves into the realm of they have intent to go get the substance and use it. Now, not to say that all clients know this. I know I often educate with clients what these all mean, but oftentimes if they have been to meetings, if they have a sponsor, if they have worked through steps at all, they have started to delineate these differences. So when you ask, are you having cravings? Or are you having thoughts of using? I don't know if you often have an assimilation of your mind that they're all kind of the same thing, but they might be reading it a different way. So, and oftentimes clients are always going to have thoughts of using, no matter how far down the road they are in recovery. If it's 1 year, 2 years, they're always going to have thoughts of using, but that doesn't mean that it leads to a craving, and it doesn't mean that it leads to an urge. It's just something that pops up in their mind. So don't freak out if they're doing really well and you're like, hey, how's everybody doing? Any thoughts of using? And like, yeah, I did the other day. And they're like, whoa, oh my God, we need to hone in on this. Don't freak out. Might freak them out. Just know that it's a thing. Let's acknowledge it. How did you move past that? So, processing the relapse. If we want to frame it as a teacher, we need to know what are the lessons. So avoid broad questions, things that are too open. You want to ask about triggers. You want to ask about the context, what was going on at the time, what was going through their mind. Maybe you can go through their halt with them. Were they hungry, angry, lonely, tired? And you want to try and build the picture around that. Now, sometimes why I say avoid broad or open questions, when you just be like, okay, what happened? Well, I relapsed. Okay, well, what was going on? I don't know. What do you mean, what was going on? Well, what led up to this? What was the relapse before the relapse? They'll be like, I don't know, it was there. I just wanted to use. You kind of got to work it backwards with them, be specific about what you're asking to lead to the information you want to get. Next slide. So working it backwards, you can ask what they used, where and when it happened, if they were with anybody else, if they were with anybody before this, did they just bump into people? Did they call them up? Did the people call your client? What was, emotion-wise, what were they feeling? Were they exhausted? Were they just happy to see old friends? Were they stressed about different things with relationships? What was going on in their head that, when placed in the right setting around the right people, would have led to these kind of things? And you can even go as far back as days before this. If it's, been really stressed out because of work or school, coming in here and doing these meetings and getting your therapy in on time, or money, anything that could have been stressing them out for days or weeks leading up to this. We want to know all the context there. And as we start to build this picture backwards, we know all these different things, then we can start to place together, what are the risk factors that brought them here? How can we mitigate those next time? And that's what we refer to as a relapse prevention plan. Next slide. So we have a client who consistently reaches 3 to 4 days of recovery before a relapse over the past 4 weeks. This has happened multiple times. Provider asks, what happened? Client says, I used. Provider, what led up to that? I don't know. It was just there. What's the issue with this scenario? You can.
I'll keep an eye out on the chat for you, Derek.
Cool. I do like an interactive didactic. So if you want to jump up and say something. Dr. Hersher looks like he's ready to.
Yes, I'm interested in this guy's recovery environment. It was just there, so I used it as kind of unhealthy, that he needs to think about what kind of people he's associating with and if that's healthy for him.
Yeah. So going into more of those specifics, and Jennifer pointed out it's too open. When you ask it too open, they're going to give you a pretty bland answer. So you want to know what's going on there. So we'll go to our next scenario. Client says, I used again. Provider says, okay, let's talk about that. What was going on that led to that? Nothing, I just wanted to. Is this the same scenario or different?
Seems like the same to me.
Yeah, could be the same thing. It's asking too open of a question. But then we don't know much else about what this client was going through up to this point. I just wanted to. Does this indicate that maybe they were entered into a meaningful recovery, or they're still kind of riding the fence of that and active addiction? We don't really know. So this would be a good time to do that assessment of their motivation for recovery. Next scenario. So client who had 17 days of recovery, is relatively new to the working recovery, has been stressed about working long hours and relationship issues. Comes in and says, I relapsed. And you start to ask questions like, okay, what happened? Where were you at? When did you relapse? And they say that the other day I was walking home from work. I was tired, so I decided to take the shortcut through downtown like I used to do a lot. I bumped into people I know in an alley and started talking. Then they offered me meth. So what do we know about getting the story backwards from client number 3?
Well, they're definitely offering a lot more details that you could then go on with, right? Sort of, we could sort of literally and figuratively walk them back on their path to work.
Yeah. And those details offer us things that we can use. So we know that, okay, we got the people, places, things. But what's the scenario? Okay, overstressed, probably exhausted. Went downtown through a path that seems like was trying to avoid because it's something they used to do, but they quit doing. And was offered by those people they used to know. So if we want to run through our triggers, that's being around people, places, things, being around the substance. What's the cause here? If we want to talk about overconfidence, cross addiction, forgetting the pain of addiction, which of those 3 impacted this scenario? Would you say maybe losing touch with the pain of addiction? Because this might indicate, all right, we're exhausted, was offered something that might give them a little pep. Maybe thought, had that positive outcome expectation. Hey, this might help me. I've been really burnt out this week. I need something that's going to keep me going. So we know that. We know maybe places to avoid. Maybe if a person would be comfortable disclosing this, maybe the specific people that were there, and say, how do we avoid those people in general? Can we find a different way home from work instead of this way? All of these different things that we can start to take that information we learned stepping backwards to find our path forwards. Change the little things that remove this as a potential cause for relapse. Next slide, please. So here's Marlatt and Gordon's relapse prevention model. When in a high-risk situation, that being walking home in that alley, bumping into people you know and you're exhausted, if you have a coping response that is effective to that high-risk situation, being like, okay, take a moment to breathe, calm yourself down, walk home, process it with somebody, call a sponsor or whoever your partner is, talk to them. and then you get through that moment where that craving turned into an urge, you feel good about that. You feel like, okay, I've got this. Maybe not in a bad way, I got this. I know I just talked about that, bad word. But that self-efficacy of I was in a situation and I got through it. Then later down the road, you have that future knowledge. Hey, this is what helped me before. Maybe I can use that again. But if you're in that high risk situation, there's no coping response. Maybe that situation gets worse. I can handle this. That's a good one, Sarah. Then you feel like, okay, I don't know how to handle this. Freaking out more. That self-efficacy goes down. Then that's when that positive outcome expectation comes in. Maybe using will help blank, whatever. Use, and then maybe feel guilty about that, or what is known as the abstinence violation effect, where I just had 120 days, I used, all those days are gone. And then it's like that loss, it's like a grief process of those days are gone. So then it might lead into the shame of losing those days, which would lead to more using, or all right, I've already lost these days, I have to restart, might as well make it worth it. I'm going to ride this negative train all the way into crazy town. So making a big go of starting over, which is actually one of the most common things that people will do before entering into any kind of rehab or detox facility. They want to go get one more hit. This is a very real thing, and that's why trying to frame the relapse as something to learn from and do differently versus that failure is a hard thing to do with clients, but very important, so that that relapse process gets quicker and easier each time it does happen, and hopefully prolongs the time before the next one. And it's not a lot of people are going to get this right the first few times. You could come up with the most elaborate and amazing relapse prevention plan with somebody, but there might be that one thing you just didn't think to, build a plan around. And that might be the thing that pops up within the first month. Most commonly, the one that gets overlooked and is more effective to leading to a relapse is any kind of grief. Because oftentimes you don't sit here and think, okay, people, places, things, make sure I don't have too much cash in hand. These are all these things I need to know I need to work on. But then who thinks, all right, what should I do if I lose somebody close to me and I need time to process? I mean, like, not that many people think ahead of like, I need to know what happens if I'm grieving. But what is also very common amongst people who have had a long time in active addiction, especially if they have a lot of connections or friends or family members who are also in active addiction. Very high rate of relapse or overdose. And right now we've had 3 overdose deaths that I know of in the past week. And I've had a lot of friends and clients come in and talk about those. And that's one that'll pop up, and it might not be one that was planned on. And whether you're new to recovery or have never had an addiction problem, grief can impact you greatly. So there's always things that get overlooked, but as long as we know how to correct those things and keep moving forward, that's how we progress through these hard times of early recovery, that being the first 18 to 24 months. And I know that sounds weird because you're like, wow, 2 years, that's a long time. Like, yeah, but that's still very early recovery. Dr. Hirschler looked like he was about to ask something. You did that sit-up thing.
I was just thinking how important in this whole model the toolbox of coping mechanisms are, to have a toolbox of ways of dealing with high-risk situations. And the bigger your toolbox and the more experience using the tools, the easier it gets, right?
Right. And that's the thing you added in there, the more experience using those tools. You can have a giant toolbox with a million different tools in it, but if you don't use any of them consistently, that's not going to be the first thing that enters your brain. It's like the learned instincts of habit, where how many of you drive? I would assume you all drive a car at some point. Now, how many of you have like I'm I'm going to exclude push start engines because those are weird. I would assume many of you at some point have used a key where you insert it into the ignition, right? Do you have to stop and think when you get into the driver's seat? All right, let me put my key in. I need to turn until the right amount of until the engine kicks over, and then you have to sit back. No, you don't put your brain through that much of an active process in starting the engine of your car. Sometimes you might not even intended to start the car as soon as you sat down, but it's so instinctual when you sit in the driver's seat, boom, it starts up. That is what a lot of the relapse behavior is and what those coping skills are. It's that I've done it this way, the same way, every time for years, for the same reasons. A learned instinct. Now, trying to change that and develop something new that's healthier, you're going to have to pick one or two, maybe even 3 different coping skills that you practice the same way, within the same time frame, for the same reasons, to build up that new habit. So yes, having the toolbox and the experience of using those tools, great. But if you have 100 tools and you used one day, you used this one another day, you used your whatever a week later, you're not building up that habit. You're just scattering different neural pathways now. And especially if you've been using since you were a kid and you don't have that neural, pruning, now you're just flooding your brain with like nonsense. So practicing the same coping skills consistently is what's going to help this the most. All right, next slide. Kind of like this yelling out commands. I don't have any more slides. So now I open it up to questions.
Yes, sir. Thank you so much. Wonderful presentation. And just want to give you a shout out for an awesome first Echo presentation. So thank you, thank you. And I love the interaction you've had in there with the scenarios. So we'll open up for any questions, comments from the group. Everyone's welcome to chime in. You can use the raise hand feature, chat in, whatever you prefer. Thank you.
No questions, just to say, Derek, thank you so much for presenting. Awesome job, and such a great reminder that we don't have to stop at patients' first comment to us. And just because they're giving us a closed off answer, that a lot of it's probably due to their shame. So there's really a whole lot of opportunities for exploration. So great presentation. Thank you.
Thank you. And then, yeah, we don't have to stop it there, and there could be a lot of shame there involved with it. Many might not even feel comfortable coming in and talking about it. But to try and make it an environment where they feel comfortable doing so. But also, if they're not given a lot of details, they might not know there are more details. In their mind, it was just there and I used it. So kind of helping them understand that there are things that led up to it.
Jen, I see you have unmuted. Did you have a comment or question?
Yeah, both. So I really appreciate your presentation, and I work with our group who have fewer than 90 days, and I have people in there who are kind of like one of your first cases who are just, can't get more than 3 or 4 days, which in some cases, as we point out, is better because they used to use daily. But at any rate, I was spending a lot of time last week thinking about this concept of days, and it's clear to me that there is so much internal shame for people when they relapse, and people are also really fearful isn't the right word, but they really don't want me to reset their days if they get a certain number of days. I just had somebody who got 45 days and had a partner OD and die. And I didn't, and she relapsed that week, so grief you were talking about, and I didn't reduce Saturdays that week, and she was really happy. And then the next week, she had a positive screen and confirmation, and I reset her days then. But anyway, I was thinking about this concept of days and where does this come from? And sometimes I would like to say to people, okay, you have 45 minus 2, instead of saying, you have, now you had 45 and now you have 0, or now you have 2. And just wonder if anybody else has thought about that, and could talk a little bit about the history of, one day at a time, but trying to get to many days.
Well, yeah, and that's what causes the abstinence violation effect. I mean, a lot of power gets placed on days, so they have this like built up importance. And that's when they're gone, that's like, oh, I really messed this up. I lost all those days. And you're right, it's not that those days are gone. Those days are still there. They're just, now we're trying to build new days. And the days kind of started way back with AA, with like, kind of going like, I've this many days without drinking. But they've kind of taken on their own form now, 50 some years later. And the way I always look at it, especially when we get into that other platitude that I love, the one day at a time, that whole concept of one day at a time, one step at a time, 1 minute at a time, whatever it may be, it's focusing on right here, right now, today. Wake up. What can I do to not use today? Don't worry about tomorrow. Don't worry about yesterday. What can I do to not use today? And then you get through today, go to bed, wake up. All right, today. What can I do to not use today? And when you get 120 days, that is 120 times that you made it through a day without using. And it keeps that power there on the days, but it's also empowering of the person to be like, I did that. Even if there is a relapse and they restart, those days are still back there in the past. I had like, if it is coming every week, I had 4 days and I relapsed, or I had 5 days and I relapsed. Any amount of days without using is amazing and should be celebrated. And it's more about, okay, how do we get that to maybe 6 days? How do we get it to 10 days? And if you want to take it from a harm reduction standpoint of, okay, what are we doing to just make sure you're safe when you do get to that 4th or 5th day and you relapse? How can we make it to where you come back next week and we celebrate another 4 days? So there's a lot of, this is why recovery gets kind of judged for being very vague, because in a lot of ways it is very vague, and it's continuously changing. Every year we're updating things and changing the definition of things. But it's more of a personal thing than it is a population as a whole. I hope that answered anything that you asked.
Yeah, I really like hearing you talk about it, and it's helpful to me, because it's hard. And the other thing that I try to celebrate with people is, in spite of relapse, advancement. Dr. Hirschler was talking about this a couple sessions ago about advancement in other ways. So I have 2 people who are relapsing a couple times a week for 3 years, but now they both have jobs and they're holding their jobs down. And so I try to point that out to them without taking a focus totally away from using, but to identify progress.
All right, that is an indicator of progress. I mean, if that's, holding down a job with something they couldn't do before, stable housing, anything like that, and they're able to do it now, that's amazing. I mean, I've had clients before where their mark of progress in their recovery was they were able to buy a car. And I can't express to you how excited they were to finally buy a car and have a car of their own that they could, use to get around, do things that they needed to do. So any little thing like that is something to be celebrated. And Sarah typed in here, reflect on the past experiences that they've had while sober, but also sobriety as a state of mind. And yeah, that's a big one. And that's where I try to do a lot of like psychoeducation with clients on the difference between abstinence and recovery. And it's not about just not doing or using a substance, but going into what are you doing that is changing in your life? Well, yeah, it's a journey, not a destination. It's all about how to get there, but it's not about being there. But it's what's changing in the way you look at life, how you're doing things to progress your health, your mental health, physical health, diet health, dental health, big one for people around here. All these different things. If you're trying to lift yourself up in some way, that's recovery. Now it's just once you can hone in on that one and be like, all right, how do we lift up these other ones? Kind of bring you into balance. That's just outstanding work.
You know, I like to think about this, Jennifer, kind of like toddlers learning to walk. You know, that they've seen people walk, and so they know it can be done, and they're stubborn as can be. You know, that they walk and then they fall, and then they walk a little bit more and they fall, but they get it eventually because they're just stubborn about it, and they keep persisting. So I look at sober days kind of like that, you know, that I'm just stubborn, and you know, you learn from it and you move forward. And seeing people who are successful is inspiring. You know, you hear how they struggled to get where they got. And so going to meetings and hearing people tell their story.
Yeah, last week we had somebody who is in our monthly group. So she has 3 years of sobriety, and she couldn't come to the monthly meeting. So I said, okay, come to our weekly group. And I just asked her to tell people there, sure, what she thought was helpful. And it was so funny because she said meetings, and that's what I tell people every week. You know, go to your meetings, but to hear it from somebody who had 3 years of sobriety, I think was a different thing than hearing it from me.
It does take a hot minute for like people to get to the realization that meetings can be helpful. And for some people they're not, and like it's not going to be for everybody. But we throw them into a mindset of have to versus get to. They're like, oh, I have to go get these in every week. But then over time, when they do start to hear other stories and be like, wow, that's amazing, I got a lot from that, then they kind of get to that, I can't wait to get there next week so I can hear another story or share my story. Because sometimes it takes people a long time to be able to share what's going on with them. So that transition from I have to be here to I get to be here is probably one of the biggest barriers. But once you get over it, that's how people get the most out of meetings. And I was add in that processing this relapse like this, this is something that can be touched on if you're in like your medication management phase of your COAT meeting, but would probably be best to leave more of the deep digging to when they're in the counseling group or doing their individual counseling, or if they come in and just you're having a one-on-one with them, go right into processing it, get all those details. But if you're like, you got your 30 minutes of trying to talk to 15 different people about where they're at this week, might not be the best time to start digging into a lot of the details here. But you can touch on it, get your main context, what was going on. That'd be a nice little warm handoff to your therapists. Any other questions, comments, or concerns, gripes or complaints?
What do you think of the smoke alarm kind of concept about slip? So like recognizing when the smoke is starting to fill the room, you know, before there's actually a full-blown fire. So, you know, how can we help patients kind of recognize that there's, do you understand what I'm saying?
Like when you're starting to notice
You know,
all
like,
the buildup before a relapse?
one of your cases was this guy who decided to walk downtown instead of, you know, so he's thinking about walking downtown. He must have been thinking about that for a while. You're like, what is the smoke alarm kind of process of this before they get into kind of making a slip? Do you follow what I'm saying?
Yeah. With like, yeah, he didn't have to go downtown route.
Yeah. So, and learning to recognize the first signs of maybe starting to wander, like planning to make a mistake or.
Yeah, those are what we call seemingly irrelevant decisions, or actually, I think we've changed that to a different acronym because saying SIDS leads you to think about something different. But it's those little decisions you make in a day or throughout a day that will lead you into a situation like that. I mean, like if I, decide, oh, I'm going to wake up a little bit later today, and then I don't have time to make coffee. So I need to have coffee before I go to work. So maybe I'm going to go to Starbucks, and then somebody bought my drink in front of me. So I'm going to do it for the people behind me. And then maybe the people behind me, that was the thing that changed their day, or it made me very late for work. And now I've missed my first appointment. It's all the going right back to, I decided to wake up late today. So that, going downtown that could have been, he's already exhausted from work, has maybe already had that thought in his mind. A little bit of meth might be helpful right now. And says, okay, I don't want to take the long way home today. I'm going to walk downtown with that intent in mind of I might see some people I know. So yeah, that could be something that led to him going there. And that would, you want to keep digging further as you're walking backwards. What made you think to walk downtown versus going the long way around? What made you decide to go down that alley in particular? Smoke before the fire. And oftentimes when you really start digging into this with clients, though, you can go pretty far back and see that this relapse started long before even the week you're in. Just as far as what's going on in their daily lives. That's why it's always good to check in on what's going on with them personally, with their stress levels, what they're eating like, if they're not sleeping well, if they're, having relationship issues, if they're on the verge of being evicted. All these different things can greatly impact a potential relapse. And sometimes you can see that coming before you even get near it. You'll start to notice when they start to get a little consistently exhausted, if they're a little bit more like scatterbrained, if they maybe start showing up a little bit later each week. Like there's just those little indicators that they're starting to come off of this stable track that we were setting. So then you can kind of just hone in on them and be like, what's going on with you? Like, how can we help? Is there something we can assist you with, like resources wise? Whatever the case may be. So you can catch them. That's more difficult to convince them that they're leading towards something, but you might be able to see it, but they don't, or at least their brain doesn't. So that's where you might need to go back in with that psychoeducation and explain to them what's going on and why they're increasing risk of relapse.
Thank you for all the questions and comments, everyone. It's been wonderful. And Derek, I never doubted you, but I just wanted to say you're doing so great facilitating all the chats and questions and everything. I know it's not easy looking at the chat and seeing when people unmute and things like that. So shout out.
It's fully okay to doubt me. I understand. I'm a guy with a big horse head in my office.
No way, Elizabeth and I love it. We always talk about that. Like, I love this hobby horse in the background. Any other questions, comments from the group? Katie chatted in saying great job in discussion. Thanks, Katie. We'll give it the echo pause here. I would hate to cut it short. We have 15 minutes, so give anyone some time to think of some stuff. No pressure if you don't though.
I do have a question. It's not necessarily related to today's didactic. And I did submit a case presentation to get into more detail on it later. But has anybody had any success in getting a Suboxone dose increase beyond 16 milligram total through rational drug therapy?
Yeah,
Who said yes?
Dina,
Adina.
but only in very specific cases, and it's only for short term, not long term, unless, well, just short term, not long term.
Right. Okay.
I've got it approved for a little bit longer. I have a guy that we raised him to 24 milligrams in the hospital. And I've had them agree to keep them on the dose for about the last 9 months, although I've had to appeal it like crazy left and right. Have you done an official appeal on this?
Oh, yes.
And they still won't do it?
No, no. And what I get back is that it can only be approved in times of crisis. And, my patient, we have ruled out every medical condition, blah, blah, blah. My patient is still experiencing these urges, cravings, and withdrawal type symptoms. And, his response is, well, what do I have to do? Have a lapse and use to have a crisis?
I think just laying it out for them, just being very specific about why you want the higher doses. What I often refer to when I write these is that it's FDA approved for up to 24 milligrams, and
Right.
that in Europe it's used up to 32. So it's well known to be safe at these higher doses. We are actually working with Medicaid, and we're talking with them about raising the doses. I think we're getting them a little more used to it. You could even mention that you spoke to other experts about it. You can name drop if you want. Honestly, because
I appreciate that.
yeah. Are you trying to do 20 or 24 milligrams?
I was just trying to take him to 20.
Yeah. I would just be very, very specific, 2.5 films, or, it just kind of lay out the, has he relapsed, I assume, since he's not on the right dose?
No, he hasn't. But he's trying not to. Yeah, he's trying not to.
I've always had a lot of success with saying, like, putting in one of the paragraphs, like, this has potential to be life-threatening because a relapse can lead to overdose, which they may not come back from. So this ultimately is life-threatening. And they tend to respond well for that.
Good point.
I wrote that down. Thank you.
Welcome. You could put something into, there's plenty of studies of 24 milligrams if you wanted to attach like a study of tolerability dosing, but just so everybody knows, I think it is getting to a point where we are pushing for them to raise the limit, and where we should really consider going higher if clinically reasonable. So good luck. Keep us updated.
Thank you. And I jotted down some information here. If I have any other questions, I might email some of you specifically to try to get the best patient care.
Laura, you're welcome to email us as well, Elizabeth and myself, and we'll try to get any questions you have answered.
Awesome. Thank you.
Any other comments about Laura's question from the group? All right, and any other questions or comments from anyone?
Just that it was a fantastic presentation, and boy, I wish you could just jump in my head so I'd have your skills when it comes to the counseling and the therapy, because as clinicians, the only time we get experience with that is like maybe through a fellowship training. I wish there was, if you all know of any workshops or any conferences like physicians can go to increase their skills when it comes to addiction counseling, I would love to hear about it and to know about it.
Well, I can try to keep you in the loop on that.
Yeah, man, I
And
really
thank
appreciate
you.
that.
I wish I could jump in your head too.
You got way more information.
The Addiction Psychiatry AAAP organization has a monthly lecture series on psychotherapy for addictions, and you should be able to attend those. So
Yeah, but I find like workshops more helpful than a lecture.
Okay.
Like my kind of brain.
Any other comments, questions? All righty, well, thank you again, Derek. It was a wonderful presentation, discussion, and thank you all so much for your questions and comments as well. That always makes it so interactive and wonderful in that collaborative nature. So thank you all so much. My only announcement is that our next session will be on January 23rd. Mark Garofoli will be presenting on pain and buprenorphine. And as Laura mentioned, she has a case for us for next time. So we're really excited about that. Any cases or questions, you're always welcome to chat in during the live sessions and let us know. We'll help you submit a case, or in the recap emails, we always attach the link to submit a case as well. So thank you all so much. Happy New Year, and can't wait to see you guys next time. Thank you.
Thank you. Hashtag plaid. Woo!